In terms of preparing the patients for therapy, the Yescarta product requires a Cytoxan fludarabine preparative regimen, at least, although that's not in the label, that's the way all the patients that were treated in the clinical trials and from whom we can extrapolate outcome data, received a combination of Cytoxan and fludarabine in the hospital and were kept in the hospital throughout the entire procedure, infusion and post-infusion, for management of cytopenias and toxicities. The Kymriah compound was developed a little bit differently. In my own clinical trial, which was the phase 2 that led to the multi-center global Juliet trial, I used a variety of lymphodepleting chemotherapies prior to administration of the CAR T cells and found that regardless, the therapy was successful for the long term in 40% of patients, which matches good with any of the other approaches to lymphodepletion and CAR T cell therapy. So there's more flexibility. In the Juliet trial, which is the basis for the label for Kymriah, patients were allowed to receive either Cytoxan fludarabine at a lower dose than what was used for Yescarta, and alternatively, they could receive a single-agent bendamustine or nothing at all if they were already lymphocytopenic at the time CAR T cells were available for treatment. That being said, about 75% got low-dose Cytoxan fludarabine, and a little under 25 got bendamustine, and a couple got nothing. There seemed to be no difference between patients that got Cytoxan fludarabine versus bendamustine, which is exactly what I would suspect from my own data, where I used a variety of different approaches to lymphodepletion. So the process of lymphodepletion, which is administration of therapy to deplete normal lymphocytes prior to administration of CAR T cells, differs between the two regimens. The regimens that were used in the Juliet trial, the Kymriah and on my own trial, were for most patients given as an outpatient, and the T cell infusions could be given as outpatients as well. Now, if patients became febrile days later, they could be admitted for management of cytokine release syndrome or other toxicities, and we didn't have them in the hospital the whole time. So I think the outpatient administration possibility for Kymriah is another logistical advantage. So there are some differences with regard to cell collection and processing prior to treatment of the patient, and then to the lymphodepleting therapy that's given to the patient prior to administration of the cells, and then the outpatient or inpatient administration. Again, what I'm saying is based on historical approaches, and I suspect going forward with Yescarta, people will begin to explore outpatient administration as well. I think that the current recommendations are based on how the studies were done, but as physicians become more and more comfortable with these products and their administration, that the setting will change as time goes on.